We are going to start at the beginning in chapter 1 in Physical Agents and Rehabilitation, 5th edition. And we're going to start by talking about the physiology of physical agents. What can we affect with physical agents? So the information in our textbook is based on the American Physical Therapy Association, APTA's Guide to Physical Therapist Practice. And this basically defines what physical therapy is in the United States. Other countries have their own practice acts and what's involved in physical therapy. But in the US, we go by the APTA's Guide to Physical Therapist Practice, where they basically define what is and what is not physical therapy. So physical agents can be a part of physical rehabilitation, but they're not the whole thing. They are tools that we can use to help change the physiology of some of our tissues, and we'll talk about how that works. They are things that we can do to help our patients achieve their rehabilitation goals. So the learning objectives for this section are, I want you to be able to describe categories of physical agents and to be able to give clinical examples of each. To be able to state which physical agents would be indicated or contraindicated for a given treatment goal. During this quarter, we are going to talk a lot about indications, contraindications, and precautions. So indications, why would you do it? When would you do it? Contraindications, when wouldn't you do it and why? And precautions are when you need to be cautious about it. We will talk about that specifically for every individual modality we discuss, but we will also talk about it in general for physical modalities. I want you to be able to state the 4 general contraindications and precautions for the use of physical agents and why each one would be contraindicated, and the purposes for documentation. So as we go through the quarter, we're going to be documenting everything we do. We're going to talk about how to document, why to document, and we'll go on with there. So here's our outline. What are physical agents? Categories, effects of physical agents, general contraindications and precautions for their use, evaluation and planning for the use of physical agents, and documentation. So physical agents basically are any energy or materials that we apply to a patient, and this includes heat, cold, water, pressure, sound, electrical currents, and electromagnetic radiation. And we apply these to a patient in order to achieve rehabilitation goals. So a physical agent usually describes a type of energy, whether it's mechanical energy or thermal energy or electrical energy. The term physical agent is used interchangeably with the terms physical modality, biophysical agent, or modality. So we often just use the shorthand way of calling them modalities. And that is what we're going to mainly do in this class. So the 3 categories of physical agents are thermal, mechanical, and electromagnetic. Thermal agents use some means to transfer energy to a patient to increase or decrease tissue temperature. If we are decreasing tissue temperature, we're transferring energy from the patient to the modality. So this includes hot packs, ice packs. Ultrasound can be a thermal agent. It can also be a mechanical agent. Diathermy, water or hydrotherapy, and water and hydrotherapy can also be a mechanical agent. So there's not a strict line, but in general, these can be thermal agents. So the temperature changes that occur in the tissues when we use thermal agents can be superficial or deep. And when we talk about each individual agent, we'll talk about which ones are better for superficial versus deep treatment. Mechanical agents apply force to increase or decrease pressure on the body. So water or hydrotherapy can also be a mechanical agent. The hydrostatic pressure from water increases pressure on the body and causes a compression effect. Traction is a mechanical agent, mechanical traction or manual traction. Compression is a mechanical agent. Ultrasound. The one thing that's not listed because it's not discussed in our textbook is soft tissue mobilization. That is also a mechanical agent, and we will be talking about that and using other sources besides our textbook, which doesn't covers soft tissue mobilization. But that's also a mechanical agent. We're applying force to the body using our hands. Electromagnetic agents apply energy in the form of electromagnetic radiation, like electromagnetic radiation or electrical current. So UV radiation and infrared radiation, those are not as commonly used in physical therapy. Laser and diathermy and electrical current. Probably the most commonly used one at this point is electrical current. You will see laser and diathermy in some clinics. It's not as widespread. And when we talk about those individual agents, we will talk about why that is. So physical agents have a lot of physiological effects. The main things that we use them for are to affect inflammation, reduce inflammation, accelerate tissue healing, to affect pain, relieve pain or decrease pain, to alter collagen extensibility. And by altering collagen extensibility, we're trying to address motion restrictions. If it is collagen tissue is the cause of our motion restrictions. Also to modify muscle tone. And there's a separate lecture on muscle tone. We'll kind of talk specifically about it. The book goes into great detail on muscle tone in chapter 5, and we're not going to talk about it in that much detail. There's a lot of neurological information in there, and we will be discussing that next quarter in our clinical neurology class. So we're just basically going to touch on it this quarter, and then we're going to move into more of it next quarter, as we do. So we've already talked a lot about inflammation and healing and pain theory in our classes this summer. And so we're just going to keep going on with that. And we talked about collagen tissues and different types of tissues in kinesiology as well. And we're going to continue with that. So as usual in this program, we continue themes throughout. So this is table 1.2 from the book, and it talks about use of physical agents, what would be indicated, what would be contraindicated at different stages of tissue healing. I don't expect you to memorize this, of course, but this is just a general guideline. So when we're talking about inflammation and healing, during the inflammatory phase, we're going to be treating things differently than we are when we're going into another phase of healing. And we'll talk about in the inflammation and healing chapter, we'll talk about the different phases of healing. So we're going to adapt our use of physical agents depending on what stage of healing the person is in. And that applies to all of the physical agents that we use. So for the treatment of pain, there are a lot of different agents that may be effective. And depending on the type of pain, we might use different agents. So the different types of pain that we talked about a little bit in pathophysiology, acute pain, referred pain, spinal radicular pain, which is basically the pain is moving in a nerve root distribution, or pain caused by malignancy because you have a tumor pressing on something. Some different physical agents may be useful for the treatment of that pain, depending. So the physical agent isn't ever the only thing that you would do to treat something. And it might be contraindicated in a certain situation with malignancy in particular. And so it's something like this. These are our tools that we're adding to our toolkit. We may use them, we may not use them. They're not always the only thing. Sometimes you go into a treatment thinking, oh, I'm going to use this. And turns out there's a contraindication and you can't use it. Well, then you go to plan B. So there's always a plan B, and that's a good thing. When we're talking about motion restrictions, motion restrictions can be caused by muscle weakness. They can be caused by pain. They can be caused by soft tissue shortening, and we can have a lot of effect on that. And what's, of course, not listed in this textbook is soft tissue mobilization, and that can really have an effect on soft tissue shortening. And a bony block is another reason why you might have motion restrictions. That you're not necessarily going to have a physical agent that affects that. You might have to go more drastic, like surgery, which of course we don't do. We see them after surgery. So for all physical agents, there are basically general contraindications. The first one being pregnancy. If somebody is pregnant, it is generally a contraindication or precaution for the application of any physical agent. We don't want to apply energy to that person's body. They are trying to build a new human being, and a lot of things can affect the development of the fetus, and we don't want to do anything that affects the development of the fetus. Really important. So does that mean that you wouldn't do ultrasound on someone's ankle who is pregnant? You might, but you want to be super cautious. Don't mess with pregnancy. Malignancy is another general contraindication. There are modalities that we use that can affect tissue healing by increasing angiogenesis, and we know that that's already increased with cancer, and so we don't want to add to that. Some of the mechanical modalities can actually break off pieces of a malignant tumor and help it to spread throughout the body. We don't want to do that either. So we don't want to mess with cancer. A pacemaker or another implanted electrical device. There are tons of different electrical devices now implanted, deep brain stimulators, implanted cardiac defibrillators, pain pumps, spinal stimulators. A lot of type 1 diabetics have insulin pumps now. So this is something we really want to know about our patient before we even consider applying any physical agents, because we don't want the physical agent to interfere with the function of their implanted device. If someone has impaired sensation or mentation, they might not be able to report to you the effects that the physical agent is having on their body. So they just might not feel it if they have impaired sensation, or if they have cognitive impairment, they might not be able to adequately communicate what is happening with them. So that's always a it's a concern. So when we're choosing a physical agent that we're going to use, we're going to take a lot of things into account. We want to be able to choose an agent that either addresses the primary problem, or the problem is most likely to respond to the intervention. So if you have something that you're saying, this is something that's really going to respond well to the intervention, or the primary underlying problem is going to respond well to that, well, that would probably be a good choice. Treatments that address more than one problem simultaneously, that's a good choice. So if you're using compression and elevation to reduce inflammation, that's probably a good choice. We also sometimes use a physical agent just for symptomatic treatment, specifically treating pain or relieving some of the issues. And so that's kind of our lowest priority. If we can do something that's going to affect the underlying problem, that's great. We want to prioritize it. If it's only for symptomatic treatment, it might not be our first choice. There might be something else that we could do. So when we're selecting physical agents, we want to consider the goals of treatment and the effects of the physical agent. Of course, we want to consider contraindications and precautions. Some people talk about contraindications and precautions as absolute contraindications, like just don't do it, and relative contraindications for precautions, like really think about it. You have to have a really, really good reason, one of those top tier reasons. There should be evidence for the use of physical agents being effective. So in our project this quarter, our evidence-based research project, we're going to pick a research article, look at it, and see if that shows evidence that the physical agent is effective. and each one of you will pick a different physical agent to look for an article on. And then cost, convenience, and availability. That is a concern. If it's something that's low cost and easy to use and readily available, well, yeah, that's nice. If it's something that is not going to be available from the patient, or the cost is prohibitive, it's probably not our best choice. We want to use something else. So physical agents have really evolved a lot in the last 20 years or so. It used to be for electrical stim, for like a home TENS unit, you had to get a prescription from a doctor. The doctor would send the prescription to the physical therapist, who would evaluate the patient, order the unit, dispense the unit to the patient, teach them how to use it, and justify it to the insurance company. Well, these days, a lot of insurance companies don't cover physical agents at all, or they don't cover home units. And so one of the effects of that has been is they're more available to the general public, and the cost has gone down. So it used to be your insurance was paying $500 for a home TENS unit that was dispensed by your physical therapist. Now you can just go on Amazon and get one for $50. Or go to Walgreens. You know, they're all over the place. So that has definitely evolved. It's a changing landscape, so it's interesting to be involved in it. So when we're using physical agents in combination, we're usually using interventions that have similar effects. So we don't want to use things that have opposite effects. One thing that decreases circulation and one thing that increases circulation sort of cancel each other out in a way. So things like compression and elevation have similar effects for moving fluid out of the area and decreasing inflammation. That's a good combination. If something addresses different aspects of the same symptoms, so that's compression and elevation are combined so the compression is increasing the hydrostatic pressure, and elevation is using gravity to help drain the fluid out of the area. So we're combining that for an effective treatment for inflammation. Physical agents are more commonly used during the initial rehabilitation sessions. And then as the person becomes less acute, we move into more active treatments. So a good example of someone that I've seen in the clinic, they had a pretty severe ankle fracture, which was treated by surgery and open reduction and internal fixation surgery, ORIF. And afterwards came into physical therapy. A lot of pain, limited weight bearing. It was difficult at first for the patient to do an active warm-up like an exercise bike or something like that, because it increased her pain. And so we started out doing ultrasound as a warm-up, and then doing some tissue work to increase tissue extensibility, and then doing the exercises. And that was effective for her at first. After her pain reduced and she had more healing, she was able to go on to a more active workout. So initially we started with the physical agents, and then we kind of went off of that onto more active physical treatments. So that's a common thing that you'll see. We want to document everything we do in therapy. Effective, accurate, and complete documentation is important for communicating with other healthcare professionals. We want to communicate examination findings, evaluations, what interventions we did, what our plans are for the future. And we also want to document how a patient responded to the interventions, whether or not it was effective. The documentation serves as a long-term record of medical and legal record, and it supports reimbursement. So a lot of people are reading your chart. The doctors reading your chart, other healthcare professionals are reading your chart, the insurance adjusters are reading your chart. Often with electronic medical systems now, the patient is reading your chart. So you want to make sure that you are communicating in an effective way so everybody can understand what you're talking about. We're going to work a lot on documentation this quarter and for the rest of your career as a physical therapist assistant.